Introduction and overview of pain. It is important to remember that pain is both a sensory and emotional experience. Pain can be defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Pain does not occur in the body without the mind reacting to and contributing to the experience. Your reaction to pain is dependent upon a variety of factors, including your current emotional state. As a result, we need to be able to discern between pain sensation and pain perception. Pain sensation is a stimulus that is received by the nervous system via nociceptors, whereas pain perception is the conscious interpretation of the nociceptive stimulus as pain. Pain sensations. Our athletes need to be educated about the difference between pain and discomfort, as well as the difference between benign pain, which is often related to sports performance, and injury pain, which is often related to actual harm. As a review, let's talk for a minute about the psychology of pain. When we experience pain, nociceptors, which are sensory neurons that respond to potentially damaging stimuli, are activated, which transmit sensory information to the brain through the spinal cord. This process is known as nociception. The stimulation of nociceptors by chemical stimuli explains why pain is felt even after removing the injurious agent that has been contributing to the pain. As long as these chemicals are still present, we may still feel residual pain from the original injury. Since nociceptors become more sensitive to the presence of ongoing stimulation, the injured athlete may actually experience increased sensitivity to noxious stimuli. This is known as hyperalgia. As you can see on this slide, once nociceptors have been stimulated through mechanical, thermal, or chemical stimuli, they carry information to the dorsal horn of the spinal cord. From here, pain information continues up to the brain. Specific brain structures involved in processing of pain information include the thalamus and the hypothalamus, the brainstem, the limbic system, and the cerebral cortex. This also includes the anterior cingulate complex and the somatosensory cortex. Transmission of pain through the hypothalamus explains many of the physical responses to pain, such as sweating, dilated pupils, and increased heart rate, pulse, and blood pressure. However, the limbic system and the anterior cingulate cortex are the areas responsible for the emotional responses to pain, such as fear, anxiety, and even sadness. Pain perception is influenced by a variety of factors. Very stressful situations, such as sport participation, the fight or flight response may cause a decrease in the physiological sensations of pain. In addition, the physiological perception of pain may be decreased because of the athlete's focus on factors other than the pain, such as training or on the competition. Emotions, behaviors, and culture, as well as gender factors, can all influence pain perception. For example, many studies have found that males will tolerate higher levels of pain than females, and that extroverts may express pain more freely compared to introverts. Remember the difference between pain sensation and pain perception that we discussed earlier. The perception of pain can be broken down into two factors, known as the pain threshold and the pain tolerance. Pain threshold can be defined as the level of noxious stimuli required for pain to be felt, whereas pain threshold is a measure of the maximal amount of pain a person can or will tolerate. Pain tolerance is often associated with the limbic system and cerebral cortex. However, both pain threshold and pain tolerance are completely subjective and individualized. They can both be influenced by the individual's history of pain as well. Pain inventory surveys. Being aware of an athlete's pain level and pain coping strategies can place the athletic trainer in a position to help the athlete with pain management. There are several different pain inventories that can be used to measure and monitor pain levels and coping. Two of those are listed here on this slide. The first is the Brief Pain Inventory, or BPI. The BPI has two skills that ask the respondent to rate severity of pain at its worst, or its least on an average and current levels. It also requires the individual to rate how much pain is interfering with their daily activities. The Sport Inventory for Pain, or SIP, is a 25-item questionnaire. There is also a shorter version called the SIP or SIP 15 that is available that contains only 15 questions. The SIP 15 is specific to the athletic training setting, and it can help to identify athletes who are not coping effectively with pain. This tool can also help to identify athletes who have had a change in pain management and as a result may benefit from the implementation of psychosocial strategies. The duration of pain. Another factor in this full processing of pain is the duration that the pain is experienced. Acute pain is pain that is of recent onset and sudden onset, and is typically high intensity pain that is localized at or near the site of injury. Acute pain is generally easy to diagnose and easy to manage. In contrast, chronic pain is pain that persists beyond the normal time expected for healing, typically a minimum of 3 to 6 months. Chronic pain is often no longer located in the area of the original tissue damage and is non-responsive to treatment attempts. The term persistent pain has been used to differentiate pain that meets the time frame defined as chronic, but is actually a symptom of a treatable condition. So, for example, a soccer player who is diagnosed with patellar tendonitis at the start of the season, but who continued to play through the full season, might have persistent pain and not necessarily chronic pain. Persistent pain is common in athletics because many athletes are unwilling or unable to rest for the amount of time needed for symptoms to resolve. Athletic trainers need to be able to differentiate true chronic pain from persistent pain. Chronic pain is much more difficult to treat because it often involves more social, emotional, and psychological input compared with acute pain, and as a result, it can be perpetuated with much less tissue damage. Complex regional pain syndrome, also known as CRPS, has two types, type 1 and type 2. Complex regional pain syndrome type 1 is also known as reflex sympathetic dystrophy syndrome. This may occur following a minor nerve injury, such as a sprain, strain, or even from surgery. Complex regional pain syndrome type 2 is known as causalgia. This can follow a more major nerve injury. CRPS involves the sympathetic nerve system and assumes an abnormal function after an injury. Athletic trainers who work with athletes to report ongoing pain should be aware of the signs, symptoms, and potential treatments for CRPS. It is commonly accepted that athletes with CRPS should not be treated with ice because it can cause additional nerve damage, and it may lead to the condition worsening and spreading to other areas of the body. There are a variety of signs and symptoms that are associated with CRPS, and you can see some of these listed on the screen. This is not an all-inclusive list of signs and symptoms, but these are the major ones that we should be able to look out for and identify. There are some red flags to consider when dealing with a patient who is experiencing chronic pain. Athletes experiencing chronic pain may be at an increased risk for suicide. As a result, athletic trainers should be aware of the psychological impact of pain. We should also make sure that we refer athletes to a mental health professional if we have any concerns for the athlete's well-being or health care. We need to remember the referral considerations that we have discussed when we're considering making such a referral. As injured athletes progress through the rehabilitation process, they're likely to experience different pain sensations in various phases of rehabilitation. An understanding of the role of pain during each rehabilitation phase can help athletes to cope with these pains and discomforts, and it can also help them to use pain as information about the physiological processes that are happening within their body. Athletes need to understand how the injury will progress and what levels of pain and disability are to be expected following surgery if necessary, and at each phase of the recovery process along the way. This can help our athletes to manage expectations and to understand what is normal and abnormal sensations of pain. Non pharmacological treatment strategies for pain management include a variety of things, such as psychosocial strategies, which we'll discuss in a few slides. In addition, we can use visual distraction, such as providing something interesting for the athlete to focus on during rehabilitation protocols or even treatments. We can also use auditory distraction, which can be something as simple as talking to the athlete or even listening to music. There are also things like massage and transcutaneous electrical nerve stimulation, also known as TENS, that are as well as other pain control therapeutic modalities that can be effective non pharmacological pain management techniques. The placebo effect is suspected to have occurred when pain reduction is obtained through mechanisms other than the physiological effects of treatment. The placebo effect is linked to a psychological mechanism, whereby if the athlete believes the treatment is beneficial, then the pain can be reduced. Research on pain control theories support the existence of the placebo effect. All modalities and other therapeutic strategies also utilize some degree of the placebo effect. Psychosocial strategies in pain management are to diminish both the autonomic changes associated with pain, such as muscle spasms and psychological distress. Athlete education is a key part in the implementation of psychosocial strategies, specifically with pain management. The athlete should be educated on the pain spasm cycle and how stress may influence the cycle. Stress management techniques such as deep breathing and progressive muscle relaxation can also be helpful for athletes dealing with pain. Imagery can be used as a relaxation strategy to distract the athlete from focusing on injury related pain. Athletic trainers can also work with athletes who have pain during rehabilitation or those with chronic or persistent pain to create a pain management plan. This plan may include both associate and dissociative strategies for pain management. Dissociative strategies are techniques that distract the athlete from the pain and focus their attention in a different direction, such as imagery scripts. Associative strategies are techniques that help the athlete interpret the pain that they are experiencing.